Cardiac dysrhythmias. 8024. Protocol. Symptomatic bradycardia and tachycardia dysrhythmias frequently have an underlying cause that should be recognized and treated. It is critically important to determine the cause of the patient's instability in order to properly direct treatment. Search for and treat possible contributing factors, H's and T's. Hypovolemia, hypoxia, hydrogen ion acidosis, hyperkalemia, hypoglycemia, hypothermia, tamponade, cardiac, thrombosis, coronary or pulmonary, tension pneumothorax, trauma, hypovolemia, increased ICP, toxins. Adult bradycardia. Protocol applies to adults who are symptomatically bradycardic with a heart rate of less than 50 BPM documented by monitor, a systolic blood pressure less than 90, and any other signs or symptoms of hyperperfusion that may include decreased sensorium, diaphoresis, chest pain, capillary refill greater than 2 seconds, cool extremities, or cyanosis. Supplemental O2 as necessary to maintain SpO2 greater than or equal to 94%. Use the lowest concentration and flow rate of O2 as possible. Profound bradycardia may require cardiopulmonary resuscitation. CPR. Electrocardiogram monitoring. Perform a 12-lead ECG. Establish vascular access with normal saline. Titrate to SBP greater than or equal to 90. Advanced airway adjuncts as needed. Okay, moving down. Symptomatic type 2 second degree block or third degree block. Move to the left, no. Move to the right, yes. I'm gonna go to the left. No. Atropine, 0.5 to 1 milligram IV IO push every 3 to 5 minutes until max dose of 3 milligrams total given. Then move on to transcutaneous cardiac pacing at 80 BPM. Adjust milliampere to capture. Move on. If SBP remains less than 90 after atropine and TCP, push dose epinephrine 0.01 milligrams per milliliter, which is 10 micrograms per milliliter. Dose is 0.5 to 2 mLs, which is 5 to 20 micrograms. IV IO every 2 to 5 minutes. Titrate to SBP greater than 90. Note, monitor SBP while administering titrating. Then we move on to transport. Now, as a side note, atropine should be avoided in patients with acute MI in 12-lead setting as defined in PD number 8827. Now we move to the yes side of the symptomatic type 2 second degree block or third degree block. We move to the right, yes, transcutaneous pacing or transcutaneous cardiac pacing, TCP, without delay at 80 BPM. Adjust milliamperes to capture. Atropine 0.5 milligrams IPIO shall be given if administration does not delay TCP. If TCP is unavailable, atropine 0.5 milligrams to 1 milligram IVIO push every 3 to 5 minutes until 3 milligrams total given. If SBP remains less than 90, after atropine TCP push dose epi 0.01 milligrams per milliliter, 10 micrograms per milliliter, dose 0.5 to 2 mLs, which is 5 to 20 micrograms, IVIO every 2 to 5 minutes. titrate to SBP greater than 90. Note, monitor SBP while administering titrating. Transport. As a side note, midazolam, if needed for sedation, IVIO-IN or IM, 4 milligrams, may give an additional 2 milligram dose. IVIO preferred route. Titrate to patient comfort. Max dose of 6 milligrams. Okay, now moving on to adult tachycardia with pulses. Narrow QRS heart rate greater than 150. Wide QRS heart rate greater than 120. Supplemental O2 as necessary to maintain SpO2 greater than or equal to 94%. Electrocardiogram monitoring. Perform a 12-lead ECG if possible. Establish vascular access with normal saline. TKO, titrate to systolic blood pressure greater than or equal to 90. Monitor pulse oximetry with advanced airway adjunct as needed. Okay, moving on. Persistent tachycardia causing hypoperfusion, acutely altered mental status, signs of shock, ischemic chest discomfort, acute heart failure. Yes to the left, no to the right. Yes, pre-cardioversion midazolam. Pre-cardioversion sedation if needed whenever possible. Midazolam, 4 milligrams IVIO-IN-IM may give additional 2 milligram dose, IVIO preferred route, titrate to patient comfort, max dose of 6 milligrams. Synchronized cardioversion, 100 joules, 200 joules, max setting. Check rhythm after each shock. Wide QRS, greater than or equal to 0.12 seconds. No. Stable. No. Synchronized cardioversion, maximum energy. Check rhythm. Then transport. Monitor, reassess. Contact-based hospital for consultation if necessary. Let's go back to wide QRS, greater than or equal to 0.12 per second. No. Go to stable. If yes, then go directly to transport, of course. Okay, if the wide QRS greater than or equal to 0.12 seconds, if it's yes, then we ask, is it stable? If yes, then give amiodarone 150 milligrams IVIO over 10 minutes, and then go to transport. If no, amiodarone 150 milligrams IV push IO. Then go to synchronized cardioversion, maximum energy, check rhythm, then to transport. Monitor, reassess, contact-based hospital for consultation if necessary. Okay, now we'll go back up to persistent tachycardia causing hypotension, acutely altered mental status, signs of shock, ischemic chest discomfort, acute heart failure. If the answer is no, wide QRS greater than or equal to 0.12 seconds. Yes, transport, monitor and reassess, contact-based hospital for consultation if necessary. No, AFib, A-flutter, or sinus tach. If that's yes, then you go to transport. If no, SVT, regular rhythm. Yes, then the Valsalva maneuver. If no response to Valsalva, consider adenosine 6 milligrams rapid IVIO, followed by 20 milliliters normal saline rapid flush. If no response after 2 minutes, adenosine 12 milligrams IVIO push, followed by 20 milliliters normal saline rapid flush. Cardioversion information. If rhythm is wide, irregular, or monitor will not synchronize and the patient is critical, treat as VFib with unsynchronized defibrillation. Synchronized cardioversion doses, 100 joules, 200 joules max setting. If no response to the initial shock, increase dose to a stepwise fashion for subsequent cardioversions to a maximum of 4 attempts. And that is the end of cardiac dysrhythmias.